In thyroiditis, antibodies are not imitating any hormone function. They are attacking the thyroid tissue. Thyroiditis is difficult to detect because early in the disease, the patient may be predominantly hyperthyroid, but may cycle ranging from slightly hyper to hypothyroid states, thus passing through euthyroid or normal states in between. So we need more than T3, T4, and TSH levels. In order to test for thyroiditis, we need to test for thyroid antibodies. Thyroid antibody testing includes thyroid peroxidase antibody and checking for thyroglobulin antibody. In Hashimoto's thyroiditis, the thyroiditis takes on a more chronic nature, and the thyroid tissue is actually replaced with lymphocytes and scarring over time. So Hashimoto's thyroiditis, patients may cycle around hyperthyroid early in the disease, but over time the thyroid is slowly destroyed, resulting in a chronic hypothyroid state. Tumors or adenomas. Functional adenomas are tumors that can cause the tissue to function too much. They are almost always benign, as in non-cancerous. Functional adenomas of the thyroid are tumors that produce too much thyroid hormone. Functional adenomas of the thyroid that are small do not cause a problem. Functional adenomas of the thyroid that are large, greater than 3 centimeters, can result in hyperthyroidism. Functional adenomas of the thyroid that result in hyperthyroidism will require treatment. So, functional adenomas that result in extreme hyperthyroidism are called nodular thyrotoxicosis. Carcinomas are not functional. They change the tissue to a non-functioning, destructive state. Cysts are fluid-filled spaces in the organ that are benign in thyroids. Thyroid nodules or bumps on the thyroid must be distinguished. We need to know if they are cysts, adenomas, or cancer. Ultrasound will differentiate between hollow cysts and solid tumors, but will not differentiate between adenomas and cancers. So we need to do nuclear imaging or radioactive iodine uptake. We inject via IV an isotope of iodine. It's called I-123. This is slightly radioactive and does not harm the thyroid, but it does allow us to take scans of the thyroid over a period of time. In thyroid adenomas, this nuclear imaging will light up. It's taking in the excess iodine to make excess hormone, and this is referred to as a hot nodule. In thyroid cancers, the iodine will not be taken up because the cancer has destroyed their function. In this case, we will see a cold nodule. Thyroid cysts will not take up the iodine either because they are hollow and empty, and this is also a cold nodule. How to differentiate cystic from solid nodules? Ultrasound. We can see the difference between the cold nodules via ultrasound. Sometimes cancers get cystic and cysts get complex. Therefore, ultrasound is of no value in some of these cold nodules. In this case, we would need a needle biopsy so that the tissue could be studied under a microscope. In radioactive iodine ablation therapy, we use iodine 131. This is a radioactive iodine, and it is destructive to the thyroid. It also allows us to image the thyroid, but the purpose of this therapy is to actually destroy the thyroid gland. The thyroid takes up this radioactive iodine, and the thyroid is destroyed. So nursing considerations in radioactive iodine therapy include that the patient must be educated about how to deal with the radioactive iodine inside their body. There is a special collection of urine and body fluids that needs to be treated much like nuclear waste. People who receive I-131 treatments are isolated in special rooms for the first night after the procedure. They must also be isolated from children, pregnant women, and immunocompromised people for several days following therapy with I-131. Thyroidectomy is another treatment for hyperthyroidism. Surgical removal of part or all of the thyroid can be indicated in certain tumors and in Graves' disease. Total thyroidectomy may be the treatment, or there may be a partial or subtotal thyroidectomy. Nursing considerations in thyroidectomy include monitoring the patient carefully post-operatively for bleeding. Blood can compress the neck structures, causing strangulation. So thyroidectomy patients are monitored carefully for bleeding immediately post-op. And if these patients have a JP drain, we must be checking the drain often. We cannot allow this to fill and go unattended. Thyroidectomy patients are monitored carefully for bleeding, and you may be ordered to remove the staples or sutures from a fresh post-op wound to decompress. This will save the patient's life. Of course, we will be checking the hemoglobin and hematocrit, and we will be waiting for the surgery team to come in. Total thyroidectomy patients need thyroid replacement hormone. Thyroidectomy patients need to be educated that voice change or loss is a common complication of thyroid surgery. This is due to damage to the recurrent laryngeal nerve, and this may resolve over time. Thyroidectomy patients require several days of careful calcium and phosphate monitoring as well, just in case the surgery inadvertently removed the parathyroid glands.